My name is Haley Ellis. I'm a medical oncologist and researcher specializing in biliary tract cancers at Mass General Brigham Cancer Institute. For over a decade, gemcitabine cisplatin has been the standard of care for advanced biliary tract cancer. The ABC-02 trial showed a median overall survival of 11.7 months, and that was really the ceiling for many years until TOPAZ-1 changed that story. Now with 4 years of follow-up, I think we can say that the benefit is indeed real, durable, and is holding up outside of the trial as well. As a refresher, TOPAZ-1 was a global randomized phase 3 trial that enrolled 685 patients with untreated, unresectable, or metastatic biliary tract cancer. Durvalumab was added to the gemcitabine cisplatin backbone for up to 8 cycles, which was followed by durvalumab maintenance. The trial met its primary endpoint. Median overall survival improved from 11.5 to 12.8 months with a hazard ratio of 0.8. Response rates favored durvalumab at 27% versus 19%, and progression-free survival improved from 5.7 to 7.2 months. Now, a 1.3-month improvement in median survival is indeed modest, but with each successive data cutoff, the hazard ratio has improved from 0.8 to 0.76 to 0.74. The curves separate after about 6 months and they keep separating. And this is the signature of effective checkpoint inhibition. The most recent data, which was presented at EASL in 2026, looked at post-hoc analysis with a median follow-up of 57 months. Updated median overall survival was 13 versus 11.4 months with a hazard ratio of 0.75. At 36 months, 15% of durvalumab treated patients were alive compared to about 7% on placebo. At 48 months, 11.8% versus 4.3% of patients were alive. So this shows that roughly 3 times as many patients were alive at 4 years. Data maturity has reached 90%, so this represents a really mature data set. In a disease where 5-year survival has historically been under about 5%, that tail of survival is meaningful. 17% of the durvalumab arm qualified as extended long-term survivors, which were defined as patients alive beyond 30 months, compared to only 9% on placebo, and this spanned all tumor types and PD-L1 expression levels. A question we think about a lot in our community is whether molecular alteration should change the first-line immunotherapy decision. The honest answer is that the data is still evolving. Within TOPAZ-1 specifically, the exploratory genomic analysis showed consistent survival benefit with durvalumab, regardless of alteration status for the most common drivers, including FGFR2 fusions and IDH1 mutations. PD-L1 expression did not predict differential benefit. The Rumini analysis, which is one of the largest real-world molecular data sets, found no genomic alteration was significantly associated with progression-free survival or overall survival benefit on multivariate analysis. There's some other data that's suggesting perhaps there's some increased benefit or decreased benefit with specific alterations, but this is still requires careful interpretation. The practical position remains clear, and our guidelines do indeed recommend that chemoimmunotherapy should be given in the first-line setting, regardless of molecular subtype. Importantly, we know that trial data matters a lot when it holds up outside of patients on trials and reflects the patients we actually treat in clinic. And we now have 2 large data sets that confirm that this data does indeed hold up in our real-world population. Rumini and colleagues published a global retrospective cohort of more than 600 patients across 39 sites in 11 countries. And this really reflected a real-world population. Patients were older, more complex than what we see on trial. And the median overall survival was 15.1 months, with a median progression-free survival of 8.2 months and a response rate of 33%. Compared to the retrospective gemcitabine cisplatin alone cohort, the hazard ratios were 0.59 for survival. And univariate analyses found no gene alterations were associated with differential outcomes. But the signal is clearly consistent with what we see in TOPAZ-1. At ASCO GI in 2026, the Optum Market Clarity analysis from the US looked at, again, about 600 patients treated in routine practice. Median real-world overall survival was 14.6 months with durvalumab plus gemcis versus 11.9 months with gemcis alone. Time to next treatment was 10.3 versus 7.5 months. And at 24 months, survival estimates were 38% versus 28%. An important finding from this data, in my impression, was that 9% of patients on the triplet never reach second-line therapy. And that really reminds us why getting the first-line treatment right matters so much in this disease. So to finish up, TOPAZ-1 has given us now 4 years of mature data showing a survival benefit that deepens over time. Real-world evidence confirms those results across now many countries and healthcare systems. So for eligible patients with advanced biliary tract cancer, durvalumab-based chemoimmunotherapy represents our new standard of care in the first-line setting. Thank you.